This was a 53-year-old male, planned for his second eye, grade 2 cataract, nothing unusual about the case. First eye was already done with a femto cataract and a toric IOL, and the second eye was also planned appropriately for a femto cataract and a toric IOL. The IOL placement was at 168, calculated by the Barrett's toric calculator, and we were planning to use the Varion overlay, which is, so the placement axis was just at about the area of my main incision. So everything has gone off well as far as the surgery goes. We are loading the lens, and all of this is of course in hindsight. If you can notice here, I prefer to use a plunger injector, but the cartridge is well inside here, which means there's no likely to be aura locking at the wound or anything. But the plunger here is actually overridden on the optic. Now, normally you would want this plunger to be at the optic-haptic junction and push it. So this will probably lead to locking of the lens quite often that can occur here. So I'm feeling a little bit of resistance, but I said, I know I can do it, and I'll push slowly, I'll push slowly, I'll push slowly, and there was a shoot. Fortunately, I think because I inject under cohesive viscoelastic, I thought I still have a lot of margin. There's good amount of cohesive viscoelastic in the bag, in the anterior chamber, and I'll get away with this. Although it was not ideal, but I'll get away with this. So I'm repositioning the IOL in the bag, and once that is done, now I have the IOL in the bag, and I notice this nice split that has occurred in the posterior capsule, and I can't see any end of it up to the equator, which means I have very little chance of even trying to convert it. So this is an extremely tricky situation. We have an entire single piece IOL, toric IOL in the bag to be placed at this axis, and I have a PCR now probably extending up to the equator. So what are the options that I have now? Either is to do a vitrectomy, make sure I don't disturb much vitreous, explant the IOL, put a 3-piece and optic capture, because in the bag may be jeopardous. But that would require too many maneuvers to be done, and I may end up from one complication to the other. So with the single piece IOL inside the bag, and particularly the toric IOL, I thought if we can try and salvage the situation somehow. And therefore here I am trying to attempt what is known as the reverse optic capture. So in a first of all, I am making sure that I end up in the axis where I am supposed to be, 168. And in conventional optic capture, you have the haptic optics in the sulcus and the optic behind the anterior capsule. In reverse optic capture, we do the reverse, which means the optic-haptic junction remains inside the bag, and I am popping out the optic above the anterior capsular axis. And why is this necessary? Because in a single piece IOL, it is the optic-haptic junctions and the haptic which is lethal if they are in the sulcus. They lead to a lot of rubbing and uveitis, inflammation, glaucoma, and so on and so forth. So after a little bit of struggle, I have managed to first make sure that the IOL is at 168. And this dumbbell kind of thing that you see is basically that is a sign of capture. If you can notice, there is a very broad area here that will be unlike in a 3-piece, because the optic-haptic junction is very broad. So now I have the haptics of the single piece behind the anterior capsular axis, and it's only this rim of the optic which will be above the anterior capsular axis, so lesser chances of iris rubbing or iris irritation and so on and so forth. During all of these maneuvers, of course, you have to make sure that there is no vitreous disturbance that is there. Therefore, always inject triamcinolone acetonide preservative-free in diluted form. And fortunately, there was no viscoelastic, vitreous that was there. Obviously, you don't, there will be some vitreous, some viscoelastic which will be behind the IOL, which may cause some intraocular pressure rise, but we prefer to give a mannitol immediately post-operatively to these patients to lower that risk. And this is the patient post-operatively doing quite well. There is, as you can see, some fibrous PCO developing, and naturally this patient is at a higher chance of developing a PCO because the square edge is not in the capsular fornices, and he's doing quite well post-operatively. So he's doing well, not much of a myopic shift, although this can lead to, because the optic is forward, you can get a slight myopic shift. But generally, if you end up with a slight myopic shift, patients are usually not extremely unhappy about that, and this patient did very well. Coming to the second case of a 62-year-old female who's had a right eye cataract surgery done elsewhere, beautiful surgery, very well-centered capsulorhexis in the bag IOL, 6/9 unaided vision, but the patient is extremely unhappy with negative dysphotopsia. So negative dysphotopsia is a feeling that you see a sort of semicircle arc on your temporal side of vision, and when you actually move your eyes, you don't see anything like that. So the patient was naturally treated very nicely, very conservatively for 6 months, year, and now this is 1.5 years post her first eye cataract surgery, and she has not neuroadapted to it. And now she's, overdue for her second eye cataract surgery, but she's very, very bothered about the negative dysphotopsia. So she said that, now I want you to do the cataract surgery, but I don't want this negative dysphotopsia to come in the second eye. So what should be the plan? How do you tackle? How do you make sure that this patient doesn't end up with a negative dysphotopsia in the other eye? There have been several publications and I think Dr. Ramamurthy has shown beautifully the various ways in which you can treat or prevent negative dysphotopsia. And this was one of the earlier papers which showed that if you have your optic above the capsule, that is, say, in the sulcus, you are likely to prevent negative dysphotopsia from occurring. This was a paper by Dr. Sam Maskett, and therefore they recommend a technique which we saw in the previous case of reverse optic capture. And typically a 3-piece design is a more suitable for reverse optic capture, and therefore we thought we'll probably plan a 3-piece for this patient. However, on pre-operative examination, she had a significant corneal astigmatism. So on one hand, you want to make sure that she doesn't have negative dysphotopsia. On the other hand, if you don't correct the astigmatism, she will be left behind with a poor unaided distance quality vision, and then probably she'll forget all about the negative dysphotopsia and be very unhappy with this unaided outcome of this eye. So we counseled the patient, we reassured that we'll try our best, but this is something, negative dysphotopsia is something that occurs in spite of all possible perfect surgery. And we thought we'll probably consider doing a hydrophobic acrylic toric IOL single piece because she had significant astigmatism, and try and do a reverse optic capture to do that. So the first question was, would you, consider doing a single piece IOL? And with some previous experience in a couple of complicated cases, we thought that we'll keep that as plan A. Important thing to keep in mind when you are doing a planned reverse optic capture is to have not only a centered capsulorhexis, but you don't want to end up making a very large capsulorhexis, because if you end up making a very large optic capsulorhexis, you will not be able to do a reverse optic capture appropriately in that eye. So we decided consciously to make a relatively small anterior capsulorhexis that was centered. And once the cataract was removed, we went ahead and placed the IOL inside the bag. We first aligned the IOL to its appropriate axis and removed all the viscoelastic from behind the IOL because that will stay trapped. If you don't remove that, that will stay trapped forever in this eye. And once that is done, we align it to the appropriate axis there where it was intended to be placed. And then we just injected viscoelastic in the anterior chamber. And again, doing the same maneuvers of trying to pop out this anterior, the optic above the anterior capsulorhexis. I managed to get it out on one side. While doing on the other side, it came off from this side. So, struggle is going on, because I also want to make sure that the toric axis doesn't get misaligned. So it's now completely captured on one side, but on the other side also I'm making sure that all through up to the optic haptic junction, it's been captured appropriately. So once again, this sign is typically a sign that you have capture has been achieved, and you'll always have a broad band here because the optic haptic junction of a single piece is much larger. Then in the end, remove the viscoelastic from front of the IOL, which you have injected to achieve the reverse optic capture. And as you can see here on anterior segment OCT, these are the fused ACCC and PCCC margin, and the optic is lying above the anterior capsulorhexis. Of course, monitor these patients post-operatively because they are likely to get more inflammation or more intraocular pressure rise in the early post-operative period. And fortunately, this patient did very, very well in terms of refraction, as well as she doesn't have negative dysphotopsia in this eye. And we were very relieved, as this was our first attempt of doing this for this eye. So I think reverse optic capture of a single piece, first of all, is possible. So it's not only the 3 piece that can be captured. A single piece also with some principles being maintained can be captured. It will require more post-operative anti-inflammatory treatment. So in most of these cases, we continue NSAID eye drops like Nepafinec group of eye drops for at least 3 months post-operatively. Some may have IOP spikes with retained viscoelastic behind the IOL. And I think it's an important tool to be kept in a surgeon's armamentarium for some of these select situations. So thank you once again for the patient listening.
Just a few comments. What I find it's easy to do the capture with is really with, if you would tilt one end of the lens up with a Sinskey hook or even a Coughlin hook and just run the cannula, just like a BSS cannula or something along the rim. Very often the capsule just flaps in very nicely, and once you have one side in, the other side is quite easy to put back into the same plane. And the other point is also, if you ever need to do a vitrectomy, anterior vitrectomy through the pars plana, then just use your retractor from the back and just pop it straight up.
Thank you for your pulse.
Yeah, my observation in your first case is, I think you used the push type of injector,
yes,
right?
Yes.
Yes,
The shooter injector.
So the problem with the push type of injector is sudden jumping of the IOL. So rather than using a push type, you should have used a screw type of
I think
injector.
there are pros and cons of all kinds of injectors. I hate the screw injector for 2 reasons. It needs to be locked inside the wound. So typically you need a slightly larger wound, so 2.3 or 2.4 instead of 2.4. And it also requires quite often the patient cooperation under topical anesthesia. I find not very predictable. So I prefer a wound assisted through shooter devices. I think each has its pros and cons, and probably in this case, if I had a screw, maybe this may not have occurred. You're right.
Thank you so much, Dr. Shail.
Just a short comment.
Yes, sir.
Excellent presentation, documentation, Shail. We had exactly a similar situation as in your second case. Law advocate who had been operated beautifully by another surgeon had persistent negative dysphotopsia. We actually handled it by placing a Salcoflex lens, which took care of the problem. And he wanted the second eye to be done. And that again required a toric single-piece lens. We had a significant discussion with him, placed the lens in the bag, and in this eye, surprisingly, he had no negative dysphotopsia. So there's still so much of enigmatic, this whole issue. We really don't know when it will happen. If I was faced with the situation that you did, I might do what I did in the sense that place the lens in the bag and see, because the patient starts noticing it almost immediately. First or second post-operative day. If they start complaining, maybe go in again and then create a reverse optic capture. The point I wanted to make was, just because they had it in one eye, it's not necessary that they are going to get exactly the same thing in the
Absolutely, sir, 100%. And I think you have also shown those wonderful cases using the ND ring device by Dr. Prakhyat Roop, which is now being made by Care Group. I think that would also be a great option to consider.
Thank you so much.